In general, the mainstay of treatment for soft tissue sarcoma is surgery with or without radiation therapy. When radiation therapy is indicated for optimal patient management, patients may experience early and late treatment-related side effects. Preoperative radiotherapy is associated with acute wound healing complications, which for the most part resolve over time. Postoperative radiotherapy is associated with chronic side effects, which the patient will experience for the rest of their lives. Typical chronic toxicities include fibrosis, limb edema, joint stiffness, and bone fracture. To minimize both early and late radiation therapy effects, treatment using radiation therapy is avoided when possible. In addition, the dose is optimized, which at present indicates the use of preoperative radiotherapy when possible, as the standard total dose is 50 gray, as opposed to over 60 gray typically used for the postoperative scenario. We have also explored other opportunities to minimize normal tissue dose through various research endeavors, which brings me to the current lecture highlighting the role of research in radiation medicine for extremity soft tissue sarcoma. This lecture will outline how the sarcoma site group at the Princess Margaret has changed the treatment paradigm from a parallel opposed pair of radiation fields to a highly conformal, targeted approach through a series of retrospective and prospective studies. The first topic of discussion will focus on the change in immobilization method for soft tissue sarcoma patients receiving radiation therapy. I'll focus on this topic first because it was an essential step to the shift in treatment paradigm. Shown in this first slide are pictures demonstrating all of the various muscle groups and compartments, color blocked according to function. Each of these muscle compartments is isolated by fascial barriers to disease spread and aid the clinician in defining radiation therapy target volumes. Immobilization of the extremity is challenging, and stabilizing rotation whilst maintaining patient comfort should be prioritized. Choosing how the limb is rotated is also an important consideration because as the limb rotates, different muscle compartments are isolated relative to the beam's eye view, which could promote normal tissue sparing and may be conducive to a simple beam arrangement, leading to improved workflow measures. When choosing an immobilization method for an extremity, one must also consider that a limb has joints which can move or change position during a radiotherapy course. Moreover, soft tissue sarcomas may arise anywhere and usually present quite large in size. To add to these complications, sarcomas are known to grow or shrink during the course of radiation therapy. A joint allows the limb to accommodate these changes. Ensuring that the limb and joint are comfortable and stable limits positional changes during radiation therapy. In the past, we used an Optical system for sarcoma radiation therapy immobilization. This device was composed of a thermoplastic material that, when heated, easily molded to the patient's contour. It hardened quickly and fastened to a plastic base sheet. In general, this system was easy to use and inexpensive. However, there was no method of attachment to the radiation therapy treatment couch, which is an appreciable limitation when considering highly conformal, advanced radiotherapy treatment techniques. These 6 pictures demonstrate previous examples of patient immobilization for soft tissue sarcoma radiotherapy. In order to affix the Optical system to the radiotherapy couch, tape or some other product was used with inadequate results for advanced treatment. Shown in the top 3 pictures are examples of the previous system in comparison to the bottom pictures, which show the new system that supported our transition from a parallel opposed pair technique to intensity-modulated radiotherapy, or IMRT. The significant advantage of the new system was that it could attach to the radiotherapy treatment couch anywhere along the length to accommodate upper and lower extremities, and in addition, could slide across the couch to effectively immobilize right and left-sided limbs. The new system was comprised of a mini vacuum cushion that stabilized limb rotation as well as provided patient comfort. This cushion is placed within a radiolucent base plate designed to attach to the treatment couch to provide accurate, efficient, and versatile immobilization. A thermoplastic shell drapes over top of the limb and attaches to this base plate. It is now sold through Bionics Radiotherapy. As a program, it was decided to immobilize outside of the treatment volume, so this system is typically placed on the foot or hand of the affected limb. Immobilization outside of the treatment volume seems counterintuitive, but allows for immobilization standardization and prevention of resimulation if the sarcoma changes in shape or size during radiotherapy. For example, one can imagine if the immobilization device was draped over the tumor and the tumor size changed appreciably during the radiotherapy course, the device would become ill-fitting and a new system would be required at some point during the treatment course, necessitating a rescan and replan. This adds unnecessary ad hoc workload burden to an institution. Additionally, any material over the tumor may contribute to a loss of the skin-sparing effect inherent to megavoltage beams. The amount of material the beam traverses, in addition to the obliquity of the beams and curvature of the limb surface, all increase the surface dose, which may, in turn, increase the chance of the patient experiencing a wound healing complication, which is a frequent acute toxicity of radiotherapy treatment. So for these reasons, it is our institutional policy to immobilize outside of the tumor volume. We place the patient in a neutral position, comfortable separation of the normal and affected limb for all treatments. The sensitive anatomy is removed from the treatment volume, and we use a 6-point setup. The tattoos are strategically placed above and below a joint for daily positional alignment. Similarly, upper extremity immobilization follows the same guidelines. The immobilization device is placed outside of the tumor volume using a 6-point setup along with alignment markings on the thermoplastic portion of the device. Following the invention of this new immobilization system, we conducted a series of clinical retrospective reviews to calculate its positional accuracy. We compared the new custom device to the established standard of the time, which was the large polystyrene vacuum cushion, otherwise known as the VacLock, shown in the bottom right-hand picture. This publication compared the positional error and workflow time of both immobilization systems. 92 patients were immobilized with the custom device compared to 98 patients that were immobilized with the polystyrene vacuum cushion. We also looked at a subset of 84 patients that received daily image guidance with 2D versus 3D imaging. And what we found was that the custom device reduced patient setup time and also the random and systematic error associated with patients' positions, which theoretically allowed for a reduction of our error margin or our planning target volume margin from 1 centimeter, which used to be our institutional standard, to 5 millimeters if 3-dimensional image guidance was utilized when compared to the VacLock system. From the previously discussed retrospective analysis, we knew that the new immobilization system improved the accuracy and efficiency of patient positioning for radiation therapy. With this new information, the sarcoma site group at the Princess Margaret wanted to improve the treatment technique from a conventional parallel opposed pair of fields to IMRT. To gather evidence in support of this change, a dose modeling study was conducted. This published paper describes a radiation planning comparison for soft tissue sarcoma of the lower extremity. We retrospectively compared a preoperative parallel opposed pair plan to a conformal approach to an IMRT technique for 24 lower extremity soft tissue sarcoma patients. In this study, we assessed target conformality and coverage, and we also assessed dose sparing to the critical normal tissues where known radiation therapy toxicities exist, such as to the bone because of radiation-related bone fractures, and also to the superficial tissues used to close the future resection site that are prone to wound complications and infection. And what we found was that the IMRT technique significantly reduced the dose to the superficial normal tissues. The technique also reduced the dose to bone. IMRT improved conformality and clinical target coverage. So from this study, we concluded that IMRT provides the capacity for beneficial change for our sarcoma patient population. So just to recap, we invented an immobilization device that proved to increase patient positional accuracy to a standard that could be used for highly conformal treatment approaches such as IMRT. We then performed a radiation planning comparison which proved that IMRT would be beneficial for sarcoma patients. With this evidence, we implemented the new immobilization system with IMRT clinically and conducted further investigations. In this next study, we evaluated all of the inter- and intrafractional patient positioning uncertainty to quantify an evidence-based planning target volume margin for lower extremity soft tissue sarcoma radiotherapy planning. The top left picture demonstrates a LINAC with cone beam CT capabilities. A cone beam CT was performed before and after each fraction to assess the inter- and intrafractional positioning uncertainties over the radiotherapy course, using internal anatomy for quantification of the isocenter alignment deviations. In addition, we measured the change in surface anatomy using surface anatomy during treatment by using an optical localization system, which consisted of an infrared camera mounted on the ceiling of the treatment room that tracked the position of optical spheres placed on the patient's skin surface at a speed of 30 Hz, or 30 times a second. So the optical localization system is shown in the picture in the top right, and the optical spheres placed on the patient's skin are shown in the bottom two pictures. This is an example of the cone beam CT guidance software. The cone beam CT image guidance software calculated the daily deviation from the planned isocenter, which was recorded for 31 patients. Over 1,300 cone beam CT scans were analyzed. In this analysis, the total systematic error for the patient population in the left-right, sup-inf, and ant-post directions was under 1.5 millimeters. And the total random error was approximately 2.5 millimeters, which allowed us to calculate a non-uniform evidence-based planning target volume margin ranging from 3.8 to 5 millimeters, using the Van Herk margin formula cited at the bottom of the slide. We also assessed the total rotational deviation in the pitch, yaw, and roll dimensions, which fell below 2 degrees for this patient cohort. Using the evidence generated from this published work, we implemented a uniform 5 millimeter planning target volume margin for our institutional planning procedure for lower extremity soft tissue sarcoma patients treated with 3-dimensional image-guided IMRT. With the new effective and efficient immobilization method, coupled with the implementation of IMRT using an evidence-based PTV error margin for radiation therapy planning, we sought to improve the therapeutic ratio for our soft tissue sarcoma patients by further investigating how to reduce normal tissue toxicities related to radiation therapy and incorporate this knowledge in our radiation therapy planning protocols. The first chronic toxicity we researched involved radiation therapy-related bone fractures. Radiation therapy-related bone fractures are a severe morbidity of combined modality treatment, including radiation therapy. Radiation therapy-induced bone fractures are difficult to treat effectively, and the patients who suffer from the side effect are usually subjected to a multitude of corrective surgeries over months or even years. It is known that higher doses of radiation therapy have been associated with a higher incidence of bone fracture. For example, there's a 10% fracture risk for patients who receive over 60 gray, as opposed to a 2% risk for those that receive approximately 50 gray. Research has also indicated that women greater than 55 years of age are at a higher risk for fracture. From one of our previous studies that's cited below on this slide, we evaluated and investigated that there's an overall crude fracture risk of 6.3%. the median fracture time is 44 months. But from this past study, we realized that there's a lack of three-dimensional information regarding the maximum and mean bone doses, the volume of bone irradiated greater than 40 grays, the radiation therapy parameters associated with fracture, such as the length of irradiated bone volume. This is just a case study example of a patient who experienced a radiation-induced bone fracture. In 2004, this patient received their first corrective surgical procedure. You can see the bone fracture in both of these anterior views. The image on the left is the superior view of the bone, and the image on the right is the inferior view. In 2005, this patient experienced a second fracture. This time, both the bone and the corrective rod broke. This patient was subjected to multiple attempts at open reduction, and internal fixation failed many times. In 2007, this patient had their most recent corrective surgical procedure. Still, this patient is experiencing pain. Because of this severe morbidity, we wanted to further analyze why these bone fractures were occurring. So we did a retrospective review to examine the relationship between the bone dose and the irradiated bone volume on the development of radiation-induced fractures for lower extremity soft tissue sarcoma patients treated with limb-sparing surgery and radiation therapy. We looked back at 21 patients who experienced 24 fractures in total. We performed a case control study in a 2-to-1 fashion. So there were 53 control patients and 21 fracture patients. These 2 patient cohorts were matched on gender, tumor size, age, beam arrangement, anatomic tumor location, radiation therapy timing, so whether they received pre or post-operative radiotherapy, and radiation therapy dose. The study time frame was from 1989 to 2004. So as you can imagine, in 1989, there were some challenges to ensure that the dosimetric properties of the plans in the past were faithfully recreated in our new radiation therapy planning system. This study, therefore, involved heavy support from medical physics. We also investigated whether there was a relationship between the maximum bone dose and where the fracture site was located. And what this study found was that the fracture risk could be reduced if the bone volume receiving greater than 40 gray was kept below 64%, the mean bone dose was kept below 37 gray, and the maximum dose anywhere along the length of the bone was kept below 59 gray. The interesting part about this study is these 3 objectives allowed us to have evidence-based bone avoidance objectives for our IMRT plans. So the research on bone fractures discussed how we're optimizing our IMRT plans by investigating normal tissue toxicities. The other normal tissue toxicity that's frequently experienced by sarcoma patients receiving preoperative intensity-modulated radiotherapy or conventional radiation therapy are acute wound healing complications. We investigated wound healing complications by conducting a phase 2 study of preoperative intensity-modulated radiation therapy for lower limb soft tissue sarcoma patients. And this study was recently published in Cancer, the May issue 2013. So the objective of this study was to determine if preoperative IMRT was effective in minimizing the dose to the skin and subcutaneous tissues that would be used to close the future resection site or future surgical flaps and reduce the risk of wound complications. Our objective was based on the comparison between the lower limb wound complication rates from a previous phase 3 trial, the SR2 trial, that investigated preoperative versus postoperative radiotherapy. And what we found was that in the preoperative radiotherapy arm, if looking just at the lower extremity, over 43% of the patients experienced severe wound healing complications versus only 21% in the postoperative radiotherapy arm. So from this point forward, I'm going to talk about these future surgical flaps, but these are basically the skin and subcutaneous tissues that are elevated for tumor removal. So they're shown in the 2 dotted lines that surround the surgical scar. So for this trial, we had to develop a multidisciplinary collaborative practice model that allowed us to transfer the virtual surgical flaps, or this surgical scar, from the patient in sarcoma clinic to our radiotherapy planning system, then back to the patient the day before surgery. This multidisciplinary collaborative practice model began in sarcoma clinic, where the surgeon marked where the future surgical scar would be located on the patient's skin. This scar was then mapped into CT space by placing a radiopeg marker on the scar for the CT simulation scan. The surgeons then used this scar in our radiotherapy planning system as a guide to delineate where the future surgical flaps would be located on the patients, as seen here marked in turquoise and labeled flaps in the top left axial view of the lower extremity sarcoma. The bottom 2 pictures show the linear accelerator, which is equipped with a cone beam CT scan, and an example of a cone beam CT scan for a lower extremity soft tissue sarcoma. Following radiation therapy treatment, at the end of the course of radiation therapy, the patient would come back and attend a pre-surgical procedure using an optical localization system that I've mentioned before for structure and dose mapping. Again, this optical localization system consisted of a camera which was placed on the ceiling of the treatment room that tracked the position of a tool that was used to mark out where the high-dose radiation therapy volume fell on the patient's skin. The surgeon would then place his incision outside of the high-dose volume that we marked the day before. This Phase 2 IMRT trial commenced July 2005. The last patient was enrolled June 2009. 59 patients were included. Our primary endpoint was acute wound healing complications occurring within 120 days of resection for lower extremity soft tissue sarcoma patients only. About half the patients were female. The mean age was 56 years, and in general, on average, the size of the tumors were about 10 centimeters. Most of the patients were high grade, and all of the patients, apart from one, were deep to the superficial fascia. Only 3 patients in this trial developed a local recurrence, none of which were near the spared surgical flaps. So the results of this trial, 18 out of 59 patients, or 30% of the patients in this trial, experienced a wound healing complication, only 6 of which needed a secondary operation to resolve the wound complication. When comparing this current IMRT, Phase 2 IMRT trial to our previous Phase 3 SR2 trial, 30.5% of our patients in this trial experienced the wound complication in comparison to 43% in the SR2 trial. This did not reach statistical significance, but we feel it was clinically significant. For this study, target coverage was prioritized, and the future surgical flaps were spared if feasible, and tumor coverage was not compromised. In order to evaluate how well the surgical flaps were actually spared, we analyzed the overlap of the surgical flaps with the planning target volume, which indicates how much of the flaps received the prescribed target dose. We also looked at a number of different parameters listed here, such as the mean dose to flaps, the mean volume of the flaps, the width, the thickness, the percentage receiving higher doses, to see if there was a difference between the complication and the non-complication cohorts. The only significant factor that was found to be statistically significant was the surgical flap and planning target volume overlap, with the complication group having significantly more of the volume of flap receiving the target dose. This is valuable information for IMRT planning. So in conclusion, the 30.5% incidence of wound complications was lower than the projected 43% from the SR2 trial for lower extremity soft tissue sarcomas, but we did not bring it down to the baseline level of 21%. IMRT was effective in reducing the risk of wound complications and also the necessity for subsequent secondary operations in patients with wound complications. And we also realized from this trial that the degree of planning target volume and flap overlap appears to influence the risk of wound complications. So as an overview, we have discussed our research involving a change in the immobilization method for soft tissue sarcoma patients, which led to a radiation therapy technique change to IMRT. We have completed a series of retrospective reviews as well as a prospective trial evaluating how to improve our patient outcomes in regards to local control, survival measures, and normal tissue toxicities. Through the process of implementing our research findings to the clinical setting, we have developed a framework for introduction of novel technology to the radiation medicine program. The next few slides will briefly outline one of the many examples of novel technology used to further investigate optimizing our IMRT planning. I've just outlined our wound complication trial, and this next trial was conducted to examine skin and subcutaneous properties involved in wound healing using near-infrared spectroscopy. The near-infrared spectroscopy system is a multi-fiber optic bundle probe which non-invasively estimates water, oxy, and deoxyhemoglobin in tissues. It's portable and can be used for any anatomical site, and it's been extensively validated in burn wound tissue viability studies at Sunnybrook Hospital. The probe measures millimeters and centimeters under the skin surface to measure oxyhemoglobin, deoxyhemoglobin, and water content. Using the same process developed for the Phase 2 IMRT trial, the optical localization system was used to map and relocate 10 to 12 points on the patient's skin throughout the radiation therapy course for these measurements. This is just one example of how we can use the framework developed for a previous trial to apply a novel technology to the clinical setting in an efficient manner. In summary, this lecture has outlined a series of research projects that change the way we treat our patients, starting with immobilization for radiation therapy, then the technique change to IMRT, then the retrospective and prospective studies supporting evidence-based treatment objectives for optimizing our IMRT planning. It is essential to have multidisciplinary discussion for every soft tissue sarcoma case. Our program is based upon the communication, support, interaction, and discussion amongst all of these groups and programs. Moving forward, our research will continue to focus on monitoring the impact of novel interventions on acute and late complications. All research involves multidisciplinary collaboration for the most favorable clinical outcomes. Our core research values center on continuous investigation with adequate follow-up time and collection of patient outcomes. I'd just like to acknowledge the team at the Princess Margaret that have helped me with my research and also this presentation. Is that okay?
Yeah, it's perfect.